Thank you everyone for joining us for this same session on common skin infections, which will be presented by Dr. Yared Getachew, and I'm going to be your host for today's session. Dr. Simon will be my co-host. Before starting off with the session, I am going to start off by saying a few things about who Yetenaweg is, what the team does, and afterwards I will be introducing Dr. Yared, and I'll be saying a few things about him, and then we will move on to the session. All right, so Yetenaweg is a non-profit organization that's registered in Pennsylvania, USA. It's entirely run by volunteer members. So currently we have 70 active volunteers, and our volunteers span across 5 different countries, and we're counting more. So Yetenaweg is engaged in several projects, and these projects are generally summed up to 4 main divisions, and these are the health promotion team, community engagement team, mentorship and skill sharing team, and the medical education team. So these CME sessions are presented to you and prepared, organized by the CME team, which is run under the medical education team. The medical education team is also responsible for research and quality improvement projects as well. So on the mentorship and skill sharing team, the main objective is both professional development, both professional and career development. So where our participants will undergo direct mentorship in order to enhance their soft skills, but also their career development as well. The other one is community engagement team, which is focused on organizing several blood drives, fundraising campaigns, and also inclusiveness projects. And the health promotion team is engaged in promoting the health of the general public, and also helping to influence health policy and its implementations. So we are more than a digital platform. As you can see, these are pictures taken from the different events that are organized, and activities that are organized by Yetenaweg. So this is a picture from our 2015 Ethiopian calendar New Year event. This is a health and the art event where we try to explore the intersection between health and art, and we also try to include several charitable activities. For example, it included donating several school supplies to underprivileged students, and also blood drive free screening for the community as well. So the other activities that Yetenaweg is known for is the health article writing competition that is done in collaboration with ROHA and the Ethiopian Medical Students Association. We have had our 3rd round of article writing competition. So we have had several grants given for our winners. So these are our winners from the 2021 and 2022 health writing competition, and these are our 2023 winners who were given a grant to go visit the Global Health Equity University in Rwanda. So the other fruit of the collaboration that came out of the collaboration between Yetenaweg and ROHA is the research and fellowship. So with the research and fellowship program that was done in partnership with Addis Ababa University Medical Faculty, we have had grants given for 4 winners, and these are our winners. Two were from the internal medicine department, and 1 from radiology, and the other one from the oncology department. And these are our winners from the research and the quality improvement fellowship program. This was also done in partnership with St. Paul Hospital. And we're coming back to our CME sessions. We have hosted several CME sessions, which are freely accessible to our health professionals. And you can get access to our previously recorded CME sessions on our YouTube channel. And so these are some housekeeping rules for us to have a smooth CME session. So this CME session is done in partnership with several societies, medical societies in Ethiopia, like the current one, which is done in collaboration with the Ethiopian Medical Association. Previously, we have partnered with the Ethiopian Society of Cardiac Professionals, Ethiopian Society of Internal Medicine, and the like. On the year 2024, we have hosted 21 CME webinars, and on average, we have attendances varying from 150 to 200, and we invite both local and also internationally renowned physicians. And this year, we have especially given attention to focus on emergency surgical and medical cases, ANT pediatrics, OBGYN, and oncology cases as well. So coming to our housekeeping rule, for attendees to get CEU points, first you need to attend the whole session virtually. The second one will be you need to fill the Google form for personal details and and the third one will be you need to score more than 50% on the quiz that will be provided at the end of the webinar. And the other thing is, please be patient with us on accessing your CEU points, as they will take 1 to 2 weeks to be delivered to your email. So we request you to be patient with us. And if you have any questions, you can write it on the Q&A box or on the chat box, as it will be collected and displayed at the end of the session for our presenter to answer the questions. And thank you for joining us all. So coming to introduction of Dr. Yared Getachew. So he's an assistant professor of dermatovenereology and the department head at Haramaya University. He earned his undergraduate degree from Juma University, graduated in 2015, and completed his postgraduate studies in dermatovenereology at Bahar Dar University in November 2022. In recognition of his potential, Dr. Yared was selected as a mentee by the International Alliance for Global Health Dermatology and completed a 1-year intensive training program and graduated in July 2023. Dr. Yared is actively involved in teaching and mentoring both postgraduate and undergraduate medical students. His academic contribution included published papers on global health dermatology and disease affecting individuals with skin of color. He has also developed training courses for frontline health professionals, which are hosted on the WHO open platform. With a strong commitment to addressing neglected tropical diseases that affect underserved communities, Dr. Yared secured a grant for a leprosy awareness project aimed at enhancing knowledge among both the general population and healthcare professionals. He's a dedicated member of the Ethiopian Dermatology and Venereology Society, and also serves on the society's continuing professional development committee. So without further ado, I will ask Dr. Yared to take the platform and continue with your presentation.
Okay, thank you, Dr. Rom, for such a nice introduction. And I would like to welcome the attendees, and I hope we will have a great time discussing about the common skin infections we see in our OPDs. Today, I would like to discuss about a few common skin infections that we encounter in our OPDs usually. So this is the outline. We will say about the common bacterial and fungal infestation, especially I'll be selective because of the vast diseases we see. And from the bacterial one, we'll discuss about Yetaweg. For the fungal one, I'll discuss about Yetenaweg. And from the infestation, I'll discuss about escapes that are very common in our daily practice. So coming to the introduction, so skin diseases are very vast, and it's believed to be that we have more than 3,000 skin diseases. Among them, the commonest one is the skin infections, especially in underdeveloped world. We have a lot of skin infections, especially associated with the neglected tropical diseases. When we say skin infections, it can be due to any external organism, usually, and it can be included also with mites and insects. But generally, we classify them as bacterial, fungal, viral, and infestations. So coming to the superficial fungal infections, commonly when we see the different types of funguses, we define them as a superficial fungal infection, which are the commonest type of fungal infections in the body, with the causative agents being dermatophytes, non-dermatophytes, fungi, and candida. And when we say superficial, they only affect the keratinized tissues like the skin, the nails, and the hair. And when we see some of them, it can include starting from tinea capitis, tinea fasciae, tinea manum, tinea pedis, and generally when it affects the most of the other parts of the body, we call it tinea corporis. And the other is subcutaneous one, that's mycetoma is the commonest one, and chromoblastomycosis, and we have also systemic type of fungal infections. When you see the commonest etiology, the dermatophytes, we classify them as with three genera, and when we see their common site of the effect in the keratinized tissues, the trichophyton, microsporum, and epidermophyton. The trichophyton tends to affect all the skin, hair, and nail, has that as the keratinized tissue, and the microsporum will affect the skin and the hair, and epidermophyton will affect the skin and nails. Generally, to simplify the pathogens of these fungal infections in the skin, the first step is the adherence of the arthrochonidia to these keratinized tissues. It can be, as I said earlier, the skin, the nail, or the hair. So with this, with the help of the proteolytic enzymes, they will adhere to this keratinized tissue and they will progress to penetration. When you say penetration, they usually use with the secretion of proteinases, keratinases, lipases, and mucinolytic enzymes are very crucial part of the fungal penetration. In addition to the penetration, these secretions will help the fungus as a nutrient from the keratinized tissue. Whenever there is disintegration of these keratinized tissues, it will be a nutrient for the fungal elements. Others, trauma can be one facilitating cause for the penetration, and there are also what we call fungal manans on the cell wall of these funguses. So these fungal manans usually help in the inhibition of our immune reaction to the adherence and penetration of these funguses. Also, it will decrease the proliferation of and keratinocyte. Finally, after these funguses get access to this keratinized tissue, they will start to have, our body will start to have a host response. But this host response is dependent on different things. The first and the main one is the patient's immune status. So in patients with poor immune status, will have penetration with the fungus and high reaction. And based on the virulence of this organisms involved is one cause that will affect the host response. So for our today's topic, I picked tinea capitis. From our practice, we see a lot of tinea capitis in a day in our OPDs, not only in specialized setups, but in primary hospitals, general hospitals, even in health centers. It's the commonest, especially in pediatric age groups. When we see its distribution, it will account about 30% of all fungal infections, and up to 92% of children under the age of 10 years will have tinea capitis, especially if these children are found in the third world, like Africa and our country, Ethiopia. So when you see the etiology, the commonest one is the trichophyton and microsporum. Globally, it's a Microsporum canis, but in Africa, Microsporum odini and trichophyton infectious are the commonest one. And even though we do not know the exact etiology of the exact incidence of this etiology, but when we see the age distribution, as I tried to mention earlier, due to a lot of factors, children, especially with peak age of 3 to 7 years, they have prone to this tinea capitis, and it's not common in adults because we have a strong immunity also, unless there is immune suppression by different causes, especially in HIV/AIDS, you will have trichophyton infections. When we see the sex distribution, boys are more likely to have tinea capitis. Some studies show about 4 times increment in the boys than girls. But when we see the ethnicity and geographical distribution, there are some studies that will show there is a genetic predisposition for acquiring this infection, but there is no a clear conclusion about that. But it's more common in African and Latin American descent children. So coming to our country, Ethiopia, it's very common, especially in children, especially in school children. And when you see a study done in 2023, it's a meta-analysis, including 14 studies, and prevalence of tinea capitis is found to be 29% in school children. It can range from 15 to 42, but it's a very high. That means almost 1 in 4 children have tinea capitis in school. And when we see the mycological profile in Ethiopia for tinea capitis, the commonest one is trichophyton. Knowing this etiology, that it's trichophyton, will help us in the selection of different antifungals in our setup. We'll see it when we talk about the management. When it comes to transmission usually occurs anthropophilic. That means from humans to humans, and it doesn't have to be a clinically symptomatic patient, but asymptomatic carriers of trichophyton can be a source of infection to other individuals. But we also have animals, especially from domestic animals. Dogs are said to be carriers of this species, and soil can be caused. But for the transmission, we can have fomite transmission, especially commonly seen using combs and hairbrushes. But sometimes you can see with sharing of the pillow, toys, and other tools can help in the transmission of these etiologies. When we come to risk factors for the acquiring tinea capitis, as I have tried to mention earlier, age and sex are the first one, and followed by local and systemic immunosuppression, especially for the systemic immunosuppression, HIV, cancer chemotherapy, and other causes of immunosuppression can be a risk factor. When we see the local risk factor for acquiring this tinea is prolonged use of steroids is the commonest one, especially in the eastern part of Ethiopia. And poor hygiene, low socioeconomic status, and genetic and racial causes have been listed as a risk factor for acquiring tinea capitis. So when you see the pathophysiology specifically for tinea capitis, it starts with invasion of stratum corneum. Stratum corneum is the top layer of the epidermis, so it will invade the stratum corneum of the skull, and within 3 weeks of period, it will start to spread on the shaft of the hair, and we will see the clinical evidence of infection on the scalp hairs. And up to 4 months, it will, in addition to the hair shaft, it will go deeper into the hair follicles, also disseminate to other hair follicles surrounding the primary site of infections. And for years, there can be asymptomatic shedding or can be clinically evident. So when we see this invasion of tinea capitis etiologies, there are broadly classified as ectotrichs, endotrichs, and favus. Whenever we say ectotrichs, it's the infection usually occurs on the outer aspects of the hair. And this arthroconodia, as you can see on the hair, there are a lot of arthroconodias on the outer parts of the skin. This is ectotrichs. These infections usually, clinically, they manifest as the hair will break a few millimeters above the skin. And usually the microsporum is a common etiology. When we say endotrichs, it will be not on the outer shaft area, but inside the hair, the arthroconodia will invade the lesion. Here, the hair will be very brittle, and they usually cut off at the level of the hair. And usually the endotrichs type of invasion will cause clinically the black dot type of tinea capitis, which we'll see later. And the last one is the favus. And usually here, it's not the arthroconodia, rather it's the hyphae we see within the hair. And there are also some air spaces in this area. So even here, when we say ectotrics with different investigations, we'll discuss later, we can see the different types of infection. So it will help us also for investigation with wood slump examination. So when we see the clinical variants of tinea capitis, it can be classified as non-inflammatory type, including the seborrheic form and the gray patch, and also the inflammatory black root and the furthest are the commonest one. When we see the non-inflammatory types, the first one is seborrheic form. So it looks like in the seborrheic form, dandruff, a simple dandruff, we know is more or less similar to the seborrheic form of tinea capitis, but the etiology is totally different in case of dandruff and tinea capitis. And when you say gray patch, as you can see in the picture, it looks like a wheat field, whitish circular type of patchy hair loss. And we can see here a breakage of the hairs, maybe above the skin. And usually common differential diagnosis is alopecia areata, but in this case, there are a lot of matured hair rather than its breakage, not the immaturity. And they have fair and sharp margin. When we come to the second type of tinea capitis, it's a black dot. As I tried to mention earlier, the black dot occurs whenever there is an endotrix pattern of invasion in the hair, that is within the hair shaft, not on the hair outer part of the hair. So here you can see there are different black dots. This is due to the breakage of the hair on the level of the skin. And sometimes, unlike the previous one, the gray patch here, there is a clear margin of hair loss. And we don't usually see inflammation. That means erythema is not usually seen in this type of tinea capitis. When you come to the other type, for the inflammatory, it's called Karen in some terminologies. Usually it is caused by the zoophilic or due to animal transmission or from the soil transmission. If there is a significant amount of inflammation, and they present usually with folliculitis-like lesions, pustules, furunculosis, and intense inflammation is seen. And what's different from the previous ones, the non-inflammatory types of tinea capitis, is here the hue is scarring. That means whenever there is scarring, there is no growth of hair after resolution of the lesion. But in the previous types, in the non-inflammatory, we have the non-scarring type of alopecia or hair loss. So the patients will have hair growth after a resolution of this therapy. So this is the worst type of tinea capitis, and it has to be treated early. And the other type is the farthest one. And here, the hyphae and air spaces are within the hair follicle. And they usually present with a thick crustacean, yellowish, and we call that scutula. And it's not common to see farthest in our setup. Sometimes patients can have ED reaction. That means due to the invasion of the fungus on the scalp, there will be an inflammatory response. So patients usually present with different morphology, the commonest being follicular or non-follicular papules and vesicles to the feet and other areas. Whenever there is a severe ED reaction, we can see what we call erythema nodosum, urticaria, and other lesions like erythema angulare centrifugum. And it's common to see in 4 to 5% of individuals or children commonly. The other thing, as a health professional, we have to differentiate tinea capitis from different entities. And generally, we have seen that there is hair loss, scaling. So in the inflammatory types, you can see pustules, tenderness, and usually they have the reactive type of lymphadenopathy in the cervical or cervical area. So I usually recommend to check the scalp whenever there is a cervical or occipital lymphadenopathy, because one of the commonest causes is tinea capitis and tonsillopharyngeal, the others one. So the top differential is alopecia areata. Here, you have a shiny skin with discrete loss of hair, but there is no epidermal lace. And when we see the hair type in alopecia areata, it is not mature. That means it's fine, colorless hairs. In tinea capitis, we see a mature hair growth. Rather, there is only breakage of the hair. And sometimes atopic dermatitis, especially in children, we can see atopic dermatitis involving the skin. Abscess, sometimes psoriasis can be seen. But in case of psoriasis, atopic differential, we see silvery skin. But usually in tinea capitis, they are gray, or in the inflammatory one, it can be, they have this wet type of scaling. And the other is seborrheic dermatitis. When we see the seborrheic dermatitis, the scaling is very noticeable. It is a greasy, yellowish type of scaling in seborrheic dermatitis. And in tinea capitis is a gray, fine or adherent scaling. And also when we see the age distribution, seborrheic dermatitis usually affects, doesn't affect children's. Rather in adults, it's commonly seen in early ages of infancy. When you come to the diagnosis, I strongly recommend the diagnosis of tinea capitis is a clinical diagnosis based on the history, the physical examination, and contact history. We have to have a clear understanding how to diagnose clinically. So in addition to that, in specialized setups where dermatologist is available, trichoscopy, wood slam examination also will guide us whenever there is a doubt in the diagnosis of tinea capitis. When we see the dermatophyte infection, for confirmation, it can be KOH, or it can be culture, or histopathology will help us in the diagnosis of these infections. But usually, and most commonly, we diagnose it clinically based on the finding and history. When we say trichoscopy, it is a dermoscopy used for the evaluation of hair. Here, there are different types of lesions. Especially, we use this type of investigation, the dermoscopy of the hair, if there is any doubt in the diagnosis of tinea capitis, especially in our setup, if an adult presents with tinea capitis, because based on the distribution, it's rare to see tinea capitis in adults unless there is immune suppression. We usually use dermoscopy or trichoscopy. So the commonest findings seen are the black dot, as we have discussed earlier, and sometimes, as you can see in the second picture, there are comma-shaped hairs can be seen. Also, sometimes shortly broken hairs can be seen in patients. And here we can see corkscrew type of hair that looks like a corkscrew. So this is also commonly seen in the microsporum type of tinea capitis. When we come to the wood slump examination, there is a petrogen that the fungal etiology will release whenever we have these fluorescent lines. Based on that, we will see we can get the different types of etiologies. For example, if you see the microsporum, it can be yellow-green or bright green. So here you can see the first picture is on the first one. There is the trichoscopic findings, but with wood slam examination, there is a color change. This is commonly seen in the microsporum type of tinea capitis. This is also in the specialized setups where dermatologists are available. Coming to the KOH, it's the commonest and routinely prescribed, routinely given investigation. So here what we see is, as you can see, the dots and septation. This is the hyphen with septation and branching. So it can be a bedside investigation, or it can be sent for a laboratory. It's very easy, usually using 5 to 10% of KOH, we can diagnose tinea capitis as a bedside case. Coming to the culture, the commonest one is the Seborrhea dextrosaccharide. So here we can see growth of different species. Unlike the previous investigations, like KOH, here we can tell what species is involved. Also, in addition to the species identification, culture will help us for testing this drug sensitivity tests, especially the antifungal drug test, synthetic test can be done. And the others can be the potato electrosagar and dermatovenereology test mediums can be seen in the best setups, especially in research centers. So here, I would like to stress on the management of tinea capitis, because as a dermatologist, we encounter a lot of mismanagement for tinea capitis. So when we see the treatment principles, I would like to stress that tinea capitis should be treated with oral antifungals only. Topical antifungals will not be effective in the management of tinea capitis. By rule, it has to be treated with oral antifungals, because when we see the pathogenesis earlier, this fungus will involve the deeper parts of hair follicle in addition to the hair shaft. The topical antifungals only address the upper parts of or the hair shaft tinea capitis. So we don't have a complete resolution with topical treatment. So by rule, the tinea capitis have to be treated with oral antifungals. And in addition to these oral antifungals, to decrease the spread of infection from individuals to individuals, we have to use adjuvant treatments like ketoconazole shampoo and other shampoos. So coming to the mode of action of the different fungal drugs, the first and the commonly used in our setup is glycopholvine. So usually it will affect the formation of these microtubules in the fungus. So these microtubules are very important for the integrity of cell of these fungal elements. And the other common medications that are available in our setup are the itraconazole, fluconazole, and terbinafine. So this itraconazole, fluconazole, and terbinafine will act on the process of the ergosterol production. And also when you see terbinafine, it will inhibit the process and increase the amount of squalene in the cell. This squalene deposition is very toxic for these fungal etiologies. So generally, they act on the microtubules and ergosterol synthesis. And when you see one by one, the first one is glycopholvine, that is fungistatic drug, and there are 2 doses. And here I also want to stress on the dosing, because it's the commonest mismanagement we face in our OPDs. So the dose can be given 20 to 25 milligram per kg per day, or 10 to 15. This is based on the micronized and the ultra micronized. The micronized has a larger particles. That means the first one that we give 20 up to 25 milligram per kg. These micronized types have a larger particle, so the absorption is very low in the GI system. But when we see the ultra micronized, we can give with the lower dose. That means 10 up to 15 milligram per kg per day. So the ultra micro size have a higher absorption rate than the micro size one. And unfortunately, in our setup, we have the micro size. That means the larger particles. So we have to give them 20 up to 25 milligram per kg per day for 6 to 8 weeks, depending on the clinical manifestation. And we don't have the ultra micro size in Ethiopia. And the other thing is, since this glycopholvine is very insoluble, we have to give them with fatty meal. This fatty meal will increase the absorption of glycopholvine. But some people and some health professionals think that they give fat meal because of the hepatotoxicity of glycopholvine. And when we see the reality and the evidences generated, the likelihood score of glycopholvine bringing hepatotoxicity is under the category of C. That means it's the rare cause of clinically apparent liver injury. So we don't have any fear giving glycopholvine for normal individuals, unless we have a clinical suspicion that the patient might have hepatic failure due to other causes. So I strongly recommend that laboratory tests are not recommended for a routine practice, especially liver function tests. When you see studies, only 5% of the patients have increment in serum transaminases, but it is mild and self-limited. So routine investigation with liver function test is not recommended, and the likelihood score is C. The other one and the commonest one is terbinafine. It's very available in our setup. Unlike the grisofulvin, the freeze-based one, this is a fungicidal type of antifungal. And when we see the dose, it's based on the weight for easy application. So weight less than 20 kg, 62.5 milligram per day, 20 up to 40, 125, and 40 and above, it will be given 250 milligram. For adults, most of the time they are above 40 kg and 250 milligram per day is recommended dose for the treatment of tinea capitis. It has some side effects like GI upset and rarely hepatotoxicity. But in our setup, when we see terbinafine, it's very effective because it addresses the trichophyton type of species, which is the commonest one in Ethiopia. The problem is terbinafine it is very costly. And when we see the economic status of individuals that has tinea capitis, they are from the low socioeconomic status, and it has been listed as the risk factor. So we usually prescribe grisofulvin, but if the patients can afford, we can also use terbinafine for the management of tinea capitis. And the other treatment options are the itraconazole and fluconazole, but they are not a standard therapy in the management of tinea capitis. Especially fluconazole has low efficacy in the management of tinea capitis. So in addition to that, we have, in case of severe inflammatory lesions, that can be keroins or severe heat reaction due to this fungal invasion, we can also use prednisolone for 1 week of therapy to minimize the inflammatory action, and it will reduce the scarring due to the keroins. Coming to the adjuvant treatments, we have different types of medicator shops, but in our setup, ketoconazole 2% shampoo is available everywhere, and we usually give them 2 to 3 times in a week for up to 1 month. So this will decrease the transmission of tinea capitis from one individual to other individuals. And it also prevents what we call the ping pong transmission. The ping pong transmission means if the transmission is not halted, it will come and go within an individual, especially in family members and sibling members. So ketoconazole 2% has to be given for patients diagnosed with tinea capitis. When we come to the prognosis, we measure the cure rate on clinical manifestation on the mycological cure rate, and the complete cure rate is a combination of this clinical cure rate and mycological cure rate. But for practicality, we usually use clinical cure rate. I think this is all about tinea capitis. I'll go rapidly to the superficial bacterial infection. I'll select its impetigo and the scales later. So coming to the classification of bacterial infections, it can be classified into 4, but the major one is the primary skin infections and the secondary infection of primary skin disease. When you say the primary skin infections, the etiologies are the main cause of, the bacteria are the main cause of infection. They started from scratch, the infection one. But when you say the secondary infection of primary skin disease, there is a primary skin disease, especially in our setup. They can have atopic dermatitis, and there'll be a secondary infection with Staphylococcal aureus. So this is called the secondary infection of primary skin disease. For our today's discussion, I picked impetigo as primary skin infection. Usually, we see it in our OPDs almost in a regular pattern. So impetigos are a superficial bacterial infection. They are very common and contagious, especially in children. They are very contagious. Even in adults, if they have a child with impetigo, they can acquire these infections. We broadly classify them as numbulous impetigo and bullous impetigo. the commonest being Nambulus impetigo, accounting around 70% of the cases. When you come to the etiology, the commonest one is Staphylococcal aureus, and followed by the group A beta hemolytic streptococcus or Streptococcus pyogenes, especially for the Nambulus type of impetigo. And Staphylococcus is the commonest one because we can be colonized. That means without infection, we can be carriers of Staphylococcus aureus, especially in the moist areas like the nasal mucosa, and sometimes in the axilla and around the rectal area, we can have Staphylococcus aureus as a carrier, not as a disease. So it can facilitate the occurrence of this impetigo, both in bullous and non-bullous impetigo. So when evaluating C8, it is the commonest type of bacterial infections, especially in children with age less than 6 years. And as I said earlier, adults can acquire this impetigo from infected children. So when you see the risk factors to acquire this impetigo, the first one is a warm ambient temperature, because commonly this Staph aureus resides in these moist areas, in the antennae layers, in the axilla, and as areas high humidity, poor hygiene, atopic deaths. That means especially in atopic dermatitis patients, the colonization of Staph aureus is very high when compared to the normal population. So in atopic deaths, they can have high cause of impetigo, and trauma can facilitate the adherence and penetration of these bacteria and will cause impetigo. When you see the transmission, it can be through person to person, direct contact, or it can be through fomites. And sometimes these fomites can be as like that of the previous one, via clothes and other tissues. When you see the root of infection, it can be due to scratching, as I commonly see is atopic dermatitis, insect bites, and papular urticaria, and minor trauma like erosions, burns, and other infections like the varicella infection can be a cause for inoculation of this bacteria to the skin and causing impetigo. So there are different states. The adherence, invasion, and establishment of infection can be seen in these impetigo lesions. When you come to the pathogenesis, and especially bullous impetigo, this group 2 Staph aureus, they have production of exfoliative toxins that are exfoliative toxin A and B. And these exfoliative toxins usually adhere, as you can see in the first picture, on the upper part of the epidermis, and they will cause cleavage of the desmoglein 1. In our skin and mucosa, we have desmogleins that are desmoglein 1 and 3, but in the skin, the upper part has only desmoglein 1. So whenever there is cleavage in the desmoglein 1 due to these exfoliative toxins, there will be a vesicle and bullous and formation in our skin. But in the mucosa, the upper part, even if the upper part is affected, the desmoglein 3 will compensate the work of the desmoglein 1. So we don't see this acantholysis or formation of vesicles, blisters in the mucosa. We call this in dermatology desmoglein compensation theory. So the exfoliative toxins affecting the upper part of the dermis will cause the bullous and vesicles in our skin. So when it comes to the clinical manifestation, we basically classify them as the early lesions and late lesions. So in early lesions, usually on the perioral area, nasal areas, there will be an erythematous macule will occur, and it usually progress to a short-lived vesicle or pustule. We don't usually see these vesicles and pustules in the Nambulus impetigo. Small short-lived vesicles and pustules will occur, and later on they will expand and they start to produce the typical honey-colored yellow clusters. For example, in the lower patient, you can see a honey-colored adherent crustacean on the chin and lower lip. And this usually expand rapidly on the face. And sometimes we can get mild lymphadenopathy in this patient. So the typical manifestation of numbulous impetigo is the honey-colored or yellowish crustation over the mouth, nose, and sometimes disseminated over the face. This is impetigo with extensive facial involvement. If non-treated, usually they are said to be self-limiting, but sometimes they will involve most part of the skin and bring a lot of complication on the child. So when we see the clinical manifestation of bullous impetigo, they usually present with small vesicles, as you can see in the picture now. And these small vesicles will enlarge to okay, like 2 centimeter bullae. And lately, in the late manifestation, they will start to have a flaccid bullae. That means up to 5 centimeters. When I say flaccid, it is not tense. It's not shiny. It's not tense usually in bullous impetigo because of the cleavage we have seen. It's the cleavage and the bullous formation is the upper part of the epidermis. It's usually flaccid. To differentiate from other differential diagnoses like bullous pemphigoid, CBDC, they have a tense blister because the bullae formation is in the lower part of the epidermis. So this is a nice clue to diagnose bullous impetigo. And finally, this bullae will rupture and will start to have a colored scaling on the children's. So we have to pick these early findings in the patient, and we can diagnose bullous impetigo usually in children's. The commonest area is the face, the genitalia, and axilla are commonest areas for the involvement of bullous impetigo. And unlike the previous one, here we have some erythema due to the inflammation. So again, when it comes to the diagnosis, like the tinea capitis, bullous impetigo is diagnosed clinically mainly. But if we suspect other differential diagnosis, or if there is any doubt on the diagnosis, we can do CBC with the slight leukocytosis, with gram stain to check the types of bacteria involved, especially the gram-positive cocci. And rarely we give culture and sensitivity if we have methicillin-resistant Staph aureus, and if there is an outbreak of impetigo, or if the patient is suspected to have post-streptococcal glomerulonephritis. But the main one is clinical diagnosis, and with indications we do investigations listed. And rarely we do histopathology if you have a doubt on the diagnosis, especially with other bullous disorders. There are autoimmune bullous disorders in children and adults. If there is any difficulty to diagnose that one, we send for histopathology. But as I tried to mention earlier, you can see in this picture, the pinkish one is the stratum corneum, and immediately on the upper part, there is a cleavage on the stratum granulosum, what we call stratum granulosum. The whole layer, this one is epidermis. But in other autoimmune bullous disorders, can be in the stratum spinosum or in the lower parts of the epidermis, especially the basal layer is affected in other autoimmune bullous disorders. It can identify from the other, but sometimes there is a diagnosis called pemphigus foliaceus, which can present with upper cleavage in these patients. So we will further diagnose them with other investigation modalities. Coming to the differential diagnosis of bullous and non-bullous impetigo, the non-bullous impetigo, the commonest one is insect bites. Herpes simplex viral infections are common around the face, especially on peri-oral area. Lips are affected in the herpes simplex viral infection. So this is the top differential diagnosis for the non-bullous impetigo. But in the bullous impetigo, there is a bullous reaction for insect bites, herpes simplex virus. Even sometimes allergic contact dermatitis can cause bullous impetigo-like lesions. But based on the history, physical examination, the age, we can identify the differential diagnosis from bullous impetigo and non-bullous impetigo. As I tried to mention earlier, when we see the clinical course of these impetigoes, they are usually self-limiting, but the problem is they can have a complication like we have seen in the previous lesion. Also, even though the treatment will not modify, they will have a post-PSG. So complications of the numbulous one is the commonest one is acute post-streptococcal glomerulonephritis, especially those who have the M protein type 1, 4, 12, and the others. There is a risk of having this PSG and acute post-streptococcal glomerulonephritis. And unlike other infections like pharyngitis and others, they don't have usually association with occurrence of rheumatic fever. And the third complication of bullous impetigo, especially in infants and immunocompromised patients, adults, there is what we call the staphylococcal scalded skin syndrome. This is whenever there is a systemic manifestation of these exfoliative toxins, exfoliative toxin A and B. Whenever it's systemic, we will have this staphylococcal scalded skin syndrome, especially in infants and immunocompromised adult individuals. Other common complications can be ecthyma, that is a neglected wound, cellulitis, erysipelas, lymphangitis, and sometimes sepsis can be seen in these individuals. So coming to the management of impetigo, we have different issues before we choose antibiotics to be topical, oral, or intravenous. But this includes the extent of skin involvement. For example, if it involves only the face or only on the lower lip, we might choose the topical type of oral antibiotics, topical type of antibiotics. But if it's a disseminated infection involving more than the face or most of the face, or it also involves the extremities, the trunk, we might proceed to oral or IV antibiotics based on the clinical manifestation. The other one is the complications. So whenever there is cellulitis, sepsis, or bacteriemia, we can go to, rather than using the topical one, we can proceed to the systemic type of antibiotics. The patient immune status is very important, especially if the patient is immunocompromised. There is a high risk of development of systemic manifestation and complications. So we tend to choose the systemic type of antibiotics. The other emerging issue is local drug resistant pattern. And globally, we have methicillin resistant Staph aureus, and currently we have vancomycin resistant Staph aureus. Even when we see data in our country, studies show that there are increments in methicillin resistance and vancomycin resistance. In the studies, it can range from 8 up to 70% for the methicillin resistance, and also for the vancomycin resistance, it can reach up to 44% in some setups, especially the hospital-acquired type of methicillin resistant Staph aureus. We have a very limited data on drug resistance in Ethiopia, and the community-acquired resistance is not well studied. So we start usually with general measures. It's the general measures as the local hygiene, cleaning the wounded area with soap and water. And sometimes we can use a wet dressing, so we can remove the crusts of the wound. And removal of this crustation will facilitate the absorption of topical antibiotics. And so healthy individual with a superficial lesion and no systemic symptoms, we usually use fusidic acid 2% cream and mupirocin 2% ointment. That are the available topical antibiotics in Ethiopia. And for our routine practice, we usually use fusidic acid 2% cream. We usually mupirocin, but for decolonization of Staph aureus. So treatment can range from 7 up to 10 days based on the clinical judgment of the physician. And if you consider a streptococcal type of infection in the numbulous type, we can give them immediately 10 days of topical antibiotics. So this table generally gives how we have to manage patients, especially in localized simple type, as I have mentioned, nucleic acid and mupirocin given, but in impetigo, in a methicillin-sensitive staph aureus, you can start with cephalexin, erythromycin, and other options like augmentin. And if we consider the patient has methicillin resistance, in our setup, I usually recommend for the use of cotrimoxazole. It can be 1 double strength dose twice daily, and a 7-day course is given. But for adults, especially age greater than 8 years children, we can also use doxycycline and clindamycin for a 7-day course treatment for methicillin resistant. Otherwise, in methicillin sensitive, we usually use cephalexin and augmentin for the treatment of impetigo, which is non-complicated. But if there is a complication of methicillin resistant, we can use vancomycin. But currently, as I tried to mention earlier, there is an emerging issue called the vancomycin resistant. So the linezolid and the daptomycin can be an option for the vancomycin resistant type of staph aureus. In dermatology, we have what we call skin decolonization. This is usually applied if there is a recurrent bacterial infection of the skin. We have colonization of staph aureus in the moist areas, commonly in the nasal mucosa and in the axilla. So we give them mupirocin ointment twice daily for 5 days, and it will be repeated for 3 months. And they also have, we also can prescribe bleach baths. Bleach baths is given twice weekly for 3 months. And this will decrease the colonization of the staph aureus in these moist areas. So the bleach baths help us for the skin, and the mupirocin usually helps us for the moist areas like the nasal mucosa and the axilla. So this decolonization will minimize the recurrence of staph aureus and streptococcal infection of the skin. So saying this, I'll proceed to my last topic, skin infestation. So when we say skin infestation, they are usually common in the tropical and subtropical areas, including Ethiopia. So when we see WHO listed neglected tropical diseases, scabies and leishmaniasis are included as infestations that have both cutaneous and systemic manifestation in case of leishmaniasis. And both these diseases are common in Ethiopia based on the geographic distribution. So scabies is listed as NTD or neglected tropical disease in 2017, and usually it affects individuals living in developing world, commonly children, elderly, and the immunosuppressed individuals, and we see around 300 million cases worldwide, and it's common in institutional settings. That means prisons, child care center, orphanages, schools are commonly affected by scabies due to its contagiously. In Ethiopia, studies have been done in a lot of areas. One study done in large scale is in Amara region, and from 1.1 million people screened, around 380,000 confirmed case of scabies was identified. So when you see the prevalence from Waredas to Waredas, it can range from 2 up to 67%. You can see how significantly it's affecting the population in our country. And to show the transmission or contagiousity of these scabies, around 75% of studied individuals have a family members affected. So when you see the transmission, it's different from the classic and the clustered one, but it's a personal household human-to-human transmission from direct contact is the main route of transmission. Also, some studies show that sexual intercourse can be a cause for the transmission of scabies because of the prolonged direct skin-to-skin contact. But unlike this classic type of scabies, in crusted scabies, we have millions of mites on the skin, and it can be per gram around 4,700 mites. But in a classic type, we only get 3 to 50 mites in the whole skin, in the whole body. but in per gram of skin in the crusted one, you can get thousands of mites. So if there is a patient affected with this crusted scabies, the transmission can be with fomites or inanimate objects, even the floor, the chair, or other things can facilitate the transmission in crusted scabies. So when we say contact, there is what we call a close contact for defining in scabies. A close contact can be defined as someone who is living in the same house, who is sharing a bed, or including sexual partners. Classroom and direct skin to skin contact is said to be as a definition of close contact. But the direct skin to skin contact is usually defined as 10 minutes of skin to skin contact. And when we say a positive contact history with close contacts, it can be with a diagnosed crusted scabies or classic scabies, or an individual who has history of itching, which is not incriminated for other diagnosis, and it can be also a typical scabies patient. So knowing this contact history or definition of contact in scabies will help you to dig out the history of contact in different individuals. When we come to the risk factors of to acquire scabies, it can be overcrowding, delayed diagnosis, delayed treatment, malnutrition, deficient hygiene, and lack of access to healthcare and food awareness can be risk factors to acquire scabies in different individuals. So when we come to the etiology of scabies, it's caused by Sacrophytes scabivar homini. It can be a male and female mites. The female mites are a little bit larger than that of the male mites. So when this is the life cycle, the egg will be converted to the larva and the nymphs, and finally to the adult scabies mite. So each stage of the scabies mite will help us for the management of scabies, and it will take around 2 to 3 weeks for from the egg to transform to adult scabies mite. When you come to pathogenesis, after 6 to 8 weeks of incubation period, patients will start to have rash and itching due to either the immediate type of hypersensitivity or delayed type of hypersensitivity. This hypersensitivity is incremented by the mites, eggs, larvae, also the fecal matters of these mites can cause the immediate and delayed type of hypersensitivity. And there is a T cell lymphocyte infiltrate in the skin with the pathogenesis. Coming to the clinical manifestation, we classify scabies as the classic type of scabies, the crusted one that has millions of mites in the patient, and the atypical forms of scabies. But when you see the pillars to diagnose scabies, a patient has to have a pruritus, a typical distribution of lesions, epidemiologic history. That means in areas that are endemic to scabies. So when we say pruritus, the typical presentation of scabies pruritus is it is nocturnal. That means it's usually worsen at night time. Like asthma, the top differential in scabies is atopic dermatitis in children especially, but unlike atopic dermatitis, which has itching day and night, and pruritus or itching of scabies is usually at night, and it can be worsened by hot bath or shower. The reason thought to be due to its worsening at night is whenever we use pajamas and blankets, the warm condition will facilitate the movement of the mite in the skin. This with the movement of the mite in the skin will elicit the hypersensitivity reaction. So they have a nocturnal or worsening of itching at night time. So they usually present 4 up to 6 weeks after the initial infestation. But some patients might not have pruritus, and we call them carriers. Based on the distribution, morphology, and number of scabies, as I've tried to mention, and we call it typical and atypical. As you can see on the illustration, this is the typical distribution of scabies in adults and in children. And when we say typical distribution of lesions, we call it a circle of Hebra. So this has circle of Hebra, as you can see, and this illustration, it will involve the palmar, the creases, the axilla, the areola of especially women, the umbilicus, and the genitals, and the web spaces are included in the circle of Hebra. This is the typical distribution of scabies infection in individuals. So typical lesions are usually burrows. It's a pathognomic lesion for scabies. We will see it later. Papules, vesicles, pustules, and sometimes atypically you can have nodular lesions and excoriation, and post-inflammatory hyperpigmentation can be seen. But as a health care worker, we have to know that the typical distribution is called the circle of Hebra, and we have to check the red dotted areas of an individual to see for the typical lesions, especially the papules, vesicles, and the burrows. And in main, penile shaft infection is common. Some studies show that it can be 80% sensitive for the diagnosis of scabies. And in women's, areolas, nipples, and vulval areas also affected, but the area have to be checked in women. It's a sensitive area to diagnose scabies. And infants and elderly and immunocompromised patients, unlike the typical distribution of the lesion, the scalp and the face can be involved in these individuals. But in healthy individuals, we don't see the involvement of scabic lesions in the scalp and the face. So the pathognomic lesion is burrow, and as you can see, there is due to the female mite excavating in the upper layer of the skin, there is a tunnel formation, usually on the palm, in the web space of the fingers and other areas. So they usually present with whitish or silver gray or brownish type of lesion with a J-shape or S-shaped of the lesion. Usually the length is 10 up to 10 millimeter. And to further diagnose this burrow, we use burrow ink test. We'll see it later. But the problem is this burrow is seen in white individuals usually. In a skin of color, we don't usually see burrows in our setup. Also, if there is excessive scratching, the excessive scratching may cause disappearance of these burrows. As you can see in this picture, the whitish lesions, the S-shaped, the J-shaped, and other seen in the knuckle and in the web space. This is a burrow in a white skin individual. As I tried to mention earlier, we don't usually see it in the skin of colored individuals. When we see the different manifestation of scabies in individuals, as you can see in white individuals, you can appreciate red erythematous papules distributed over the trunk, the axilla, which is the circle of Hebra, and the upper extremity. Also, you can see it on the lower leg. This is what we see on the third picture, is what we call the burrow, which is pathognomic for the diagnosis. We say that it's white, grayish, or it can be brownish in color. And here we can see the erythematous papules over the shaft of the penis, and also here some nodular lesions on the glands, and also nodular lesions in the axilla is seen in these pictures. When you come to in a skin of color individuals, it's really difficult to see erythema in black or skin of color individuals. We generally see papules in the typical distribution, that is a web space, the wrist, the axilla, areola, and other areas. But we can also appreciate different physical formation in the palms. You can see here papules over the dorsal aspect of the feet, on the knee, also in the shaft of the glands, also in the penis can be seen. As I tried to mention earlier, if there is any diagnostic confusion, we have to check. In males, the penis have to be checked, because studies show 80% sensitivity for the diagnosis of scabies. These are our patients. So this patient present with chronically with lesions. He has pustules over the hand, over the web spaces and dorsal aspects of the hand. In this patient, you can see the excoriations, erosions, also some skin-colored papules over dorsal aspects of the hand. Also, you can see the super infection and crustation over the penis. This is also another patient with diffuse lesions over the genitalia and the buttock area. This is one of the commonest areas for the involvement of scabies, because these scabies mites usually prefer the moist and thin layered skin, which is non-hair bearing, because hairy areas cannot be an ideal area to establishment of these female mites in the skin. You can see here a patient with over the hands, and in the later, you can see an infant with lesions over the soles and also in the dorsal aspects of the feet. This is one of my patients when I was back in residency. As you can see, multiple bullous lesions over the hand, over the palmar creases. There is a secondary superinfection of scabies. As you can see on the lateral aspect, there is also involvement of the sole and the dorsal aspects of the foot can be seen in this patient. When you see the variant of scabies, unlike the typical or the classic type, there is a nodular type, usually seen in the genitalia and the axilla. So unlike the previous vesicles and pustules and papules, here a larger firm lesion can be seen. It is called the nodular type of scabies. You can see it on the axilla. The other variant of scabies is the bullous type. So you can see on the palm, you can see on the sole, and usually this bullous type of variants of scabies is seen in infants and old age. So the chronic manifestation of scabies is crusted, if not treated. When we say crusted, millions of mites are seen in an individual. Usually, they have other diseases that can precipitate for the occurrence of crusted scabies. The commonest being leprosy, paraplegics, and HIV-infected patients. For example, if you see leprosy, they have sensory loss. So one defense mechanism in scabies is scratching. Whenever there is scratching, there is exfoliation of this scabies mite. But in leprosy, they have lost their sensation in the hand, in the legs, so they're not scratching. They lost the primary defense mechanism in scabies. Also, patients with cognitive deficiency, physical disability, also patients with major depressive disorders, they might have a crusted scabies as a manifestation. Usually, this will take months to develop. So patients usually present, as you can see here, there is a highly crusted lesion, whitish hyperkeratotic plaque lesions over the dorsal aspect of the hand. The palmoplantar regions also involved. And unlike the classic type of scabies, in crusted scabies, there is some subungual hyperkeratosis with the involvement of the nails, as you can see in the lower lesions. Unlike the classic type of scabies, in crusted scabies, the itching is minimal, or the totally might not have itching. So whenever if you see patients with this type of lesions, you have to consider scabies, crusted scabies, and dig out for other comorbidities that can have mental illness or sensory loss, or that can affect the nerves. So this was my patient when I was back in residency again. He presented with a skin lesion of 8 months, and he presented to our OPD, and we evaluated him. And unfortunately, you can see here a diffuse hyperkeratotic lesion that looks like wood appearance, and sometimes stone appearance of lesions can be seen on the palm and sole of the patients. He has also, unlike the classic type of scabies, there is involvement of the scalp in crusted scabies. You can see the buttock area with a hyperkeratotic thick lesions. Also, the glands in the shaft of the penis is involved. And this patient was diagnosed to have a major depressive disorder, and he has been treated with different modalities, and he was improved. The other rare types of scabies are scabies incognito. Whenever we say incognito in dermatology, it means they have been treated with steroids. We have scabies incognito with misdiagnosis. The patient is treated with atopic dermatitis, and unfortunately, it will be scabies, and patients will have scabies incognito. And other times, vasculitis and animal scabies can be seen. In case of animal scabies, it's usually self-limiting. It doesn't need treatment. Coming to the diagnosis of scabies, there are diagnostic criteria by the International Alliance for the Control of Scabies, and we can also use Burrow ink test. And for definitive diagnosis, there is dermoscopy, microscopy, histopathology, and PCR can be given. But like the previous lesions, it can be diagnosed in the lower level clinically. When we see the diagnostic criteria for the International Alliance for the Control of Scabies, they classify diagnostic criteria, the confirmed one, that is with investigations, can be by visualization of the mite, the egg, or the feces, and there is also clinical scabies. So in clinical scabies, if you see a scabies burrow, typical lesions affecting the male genitalia, and with typical distribution and two history features, that means the itching and contact history. If you have one of them, you can diagnose it as a clinical scabies, and the other one is suspected scabies with the typical lesions, typical distribution, but only one history, either itching or a positive contact history. With one of these, we can say it's a suspected scabies. And the other one is a atypical lesion with atypical distribution. But if the patient present with two history features, that means the pruritus that is worsening at night, and if it has positive contact history, we defined it earlier, we call it a suspected scabies. So this is the International Alliance diagnostic criteria. There it is very helpful, especially in large steps. But sometimes in some studies, for sub-Saharan African, there is a criteria diffuse itching with cutaneous lesion, two typical locations, and if there is a contact history in the household, it says to be scabies. But when they say the sensitivity and specificity, they have 100% sensitivity and specificity. They have to fulfill all these three criteria. But the widely accepted one is the International Alliance for the Control of Scabies criteria, which is adopted even by the World Health Organization. The other is the Burrow ink test. So if you see a burrow or the triangle sign with dermoscopy, you will apply an ink to that area. And as you can see, the ink will get into the tunnel, and we'll see this S-shaped or J-shaped or other types of burrows in the skin. And here it's a magnified picture of this burrow. We can see the mite, and we can see the eggs in the burrow with the burrow ink test. It's very simple bedside test. You apply ink and you will clean it with alcohol, and you will see a staining of the burrow. And with higher magnification, you can diagnose with eggs and the mite. When you come to dermoscopy in specialized centers where dermatologist is available, you can use dermoscopy. There is what we call a triangle sign. On the triangle sign, as you can see, this is a body part of the scabies mite, dense body part, and the small arrows here shows the eggs of the scabies mite. So we call it a delta wing jet shape. So you can see this is a delta wing shape. So they appear the same, or we call it a triangle sign. For another confirmation, we use a microscopy. We can see the mites, the egg, or even the fecal matters of mites can be based on the magnification we use. Histopathology, we don't usually prescribe histopathology, but in histopathology, as you can see, eggs can be seen in the stratum corneum. Also, mites can be body parts or slice of the mites can be seen in the stratum corneum. Sometimes we have prevascular inflammatory cells with majorly eosinophils can be seen due to the hypersensitivity reaction. And the most important part not to forget is the complications of scabies. Can be the commonest one, and you have seen it in the previous pictures. Secondary bacterial infection is the commonest complication seen in scabies, and followed by the post-streptococcal glomerulonephritis, especially if the beta-hemolytic streptococci is involved. The patients or children can have PSG, and we have to look for the history of scabies in patients diagnosed with post-streptococcal glomerulonephritis. Rarely, patients can have lymphangitis, septicemia, and some psychological trauma and acrophobia, delusion of parasitosis can be complication of scabies. But we don't have to forget secondary bacterial infection and post-streptococcal glomerulonephritis. When it comes to differential diagnosis, it's most likely the top is atopic dermatitis, and followed by contact dermatitis, and other top differentials can be discussed. Coming to general measures and the preventions, the general measures include, if you diagnose scabies, all family members have to be treated simultaneously, not in another time, but they have to be treated simultaneously to discontinue the transmission. And we have to wash clothes with hot water, especially above 50 degrees Celsius is said to be that kills the mite. And if it's not non-washable, we have to iron it or keep it in a warm area for 2 weeks in a plastic bag. And we have to repeat treatments after 1 week. So this table shows different management options, but in our setup, the best one is permethrin 5% cream. So they will apply it at night time below the neck, and they will repeat it and wash in the morning. And the same will be done after 1 week, because they are not ovicidal. They usually target the mite, not the ova. So ovicidal, since they are not ovicidal, they have to be repeated after 1 week. And the other one is benzyl benzoate is available in our setup. Also, sulfur is available in our setup. But in as for mass drug administration, we can use tablet ivermectin can be given. And here, what we have to know is special situations, especially for pregnancies and young infants, we have to choose the best management, especially the commonly recommended one is permethrin. In pregnancy, we don't have to use ivermectin. In infants less than 15 kg or 2 years age, we don't have to use ivermectin tablet. And as I've tried to mention earlier, they have to be commonly repeated after 1 week to target the ova. So in the management of cluster scabies, unlike the previous one, we treat them with ivermectin tablet for 5 different occasions weekly, and permethrin will be given for 7 days in the first week daily and twice weekly until cured. But this patient is present with hyperkeratotic lesions, so we have to use keratolytics like salicylic acid and lactic acid. And nails should be shortened, and we have to apply the medication below the nails even. To address the itching, we have to use systemic antihistamines. Sometimes topical steroids can be given in severe cases, but if in nodular scabies, we can use intralesional steroids, potent topical steroid, and other topical picrolimus can be given to address the management of nodular scabies. And new medications are being on production. The famous one being moxidectin, and it has a longer half-life, and it will decrease. It's more effective than 2 doses of ivermectin. So this is a special situation I have mentioned earlier. And for follow-up, we have to appoint them after 2 weeks and after 1 month, and we'll see if there is persistence of itching and the lesion. So these are my references, and this is all about the commonest skin infections we face in dermatology department. I think now I can open the floor for Dr. Miro. So thank you all.
Thank you, Dr. Yared. We will now be moving to the question and answer session. The questions from our attendees will be displayed by Dr. Simon, and you will be answering them. In the meantime, we're going to be sharing the link to the quiz of today's session, and our attendees will be filling out the Google form. Simon, you can display.
Okay.
Dr. Yared, if you can stop sharing your screen.
Okay.
Yeah.
Okay, so is my screen visible?
Yes, it is visible.
Okay. Dr. Yared, we have around 14 questions so far. So the first question reads, how do we differentiate tinea capitis from staphylococcal folliculitis of scalp and folliculitis decalvans? And what are some treatment recommendations?
When we see the common stop differential is, as mentioned, the staphylococcal folliculitis, and rarely folliculitis decalvans can be seen. But in case of tinea capitis, they usually present start with scaling, dandruff-like scaling, and it will progress to have inflammatory lesions and pustules. But in case of staphylococcal folliculitis, they usually start with erythematous lesions, and usually they have this painful type of lesions. And for recommendations, we usually treat them with systemic or topical or systemic antibiotics are given for staphylococcal folliculitis. Also, in folliculitis decalvans, we can also give systemic therapies, antibiotics for its anti-inflammatory effect. And I think
Okay.
we can proceed to the second question.
Okay, yeah. Thank you, doctor. So the second question reads, micro size versus ultra micro size, are both available in our setup?
Actually, I have just mentioned earlier the micro size and ultra micro size. The difference is on the particle size. In the micro size, one particle is around 1 micrometer, and in the ultra micro size, it's only one. There is around 1/4 difference. And what's available in our setup is a micro size type of grisofulvin. That is why we use higher dose of grisofulvin, that is 20 up to 25 milligram per kg per day for 6 to 8 weeks. In ultra micro, it's lower dose because of its higher absorption.
Okay, thank you very much. The third question reads, what is the maximal dose of grisofulvin for adults and for pediatric patients?
We usually use the dose of 20 up to 25 milligram per kg per day dose of for grisofulvin. And so the maximum dose will be 25 milligram per kg per dose. But in pediatric patients, especially if they are below the age of 2 years, even if we don't have it, they can give 10 milligram per kg, but the maximum dose is 25 for our setup, 25 milligram per kg per day for 6 up to 8 weeks.
Okay, thank you very much, doctor. The other question we have reads, why is grisofulvin recommended to be taken with fatty meals in patients with hepatobiliary issues, considering this could put extra strain on the hepatobiliary system?
Okay, for this one, it's specific. It's based on the clinical decision of the physician. Why we recommend fatty meals is because it will facilitate the absorption of grisofulvin. As we have mentioned earlier, grisofulvin is very insoluble, so we have to give them fatty meals, especially at night time because of the phototoxicity. If the physician thinks there is liver or hepatobiliary issues, we have another option. Terbinafine is the best management for this type of individuals.
Okay, thank you very much for that, doctor. The fifth question reads, how common are autoimmune blistering diseases like pemphigus vulgaris in children to consider in differential diagnosis of bullous impetigo?
Actually, pemphigus vulgaris and bullous pemphigoid are not common in children. We see them in old age, especially age greater than 60 years. In children, there is a type of bullous pemphigoid, we call it chronic bullous disorder of childhood, or CBDC, we call it CBDC. So we commonly see CBDC, and we have some patients in our setup. Otherwise, pemphigus vulgaris and bullous pemphigoid are very rare in children.
The sixth question reads, how do we manage inflammatory forms of tinea capitis like Heron and Favus?
So when we see the management of tinea capitis, we have to give them totally systemic or oral antifungal, grisofulvin or terbinafine. This will be applied for Heron and Favus also. But if if there is a severe inflammatory lesion in carotid and fovea, we can address them with 1 week of prednisolone treatment for this patient. So we can minimize the scarring related to carotid and fovea. Otherwise, the same applies for the classic type of tinea capitis.
Okay. The seventh question reads, can we consider steroid treatment for inflammatory type of tinea capitis for immunocompromised patients?
One thing we have to know is that all inflammatory types of tinea capitis, we don't have to give them steroid unless there is a fear of scarring or a severe forms of carotid present in that patient. So we don't usually give steroids for the inflammatory. It's not recommended to give inflammatory type. But in addition to that, if it's immunocompromised, I totally will not give steroid for these patients. But they have to know that inflammatory types will not be treated right and left with steroids.
Okay. The eighth question reads, do you come across skin allergy related to terbinafine?
When I was back in my residency, I have seen one patient taking terbinafine and having the phototoxic type of skin allergy. Otherwise, it's not common to see a skin allergy to terbinafine. But I have seen one patient that's exacerbated by sunlight exposure. But the commonest allergy is with ketoconazole with sun. Okay.
Okay, thank you, doctor. Question number 9 reads, how can we differentiate balanitis from genital scabies?
Okay, in balanitis, usually it's a circumferential lesion, and it can have scaling, and it can be a shiny lesion. But in genital scabies, the patient is present with initially with erythematous papules that can progressively goes to pustules and crustacean, unlike that of balanitis.
Okay. Question number 10 reads, in cases of suspected cellulitis, what are the key clinical features that can help distinguish it from conditions like DVT or necrotizing fasciitis?
Suspect to say what are the clinical features? Okay, the main feature is we have, I think, in DVT, we have some maneuvers we have to do, and you have to check that one. In necrotizing fasciitis, it is a very deep lesion with scar formation. A scar means a necrotic tissue can be seen. But in cellulitis, they usually present a diffuse type of erythema and swelling, but it's easy to diagnose from necrotizing fasciitis and others. In DVT, there are maneuvers to do.
Okay. Question number 11 reads, when treating impetigo, how should a clinician decide between topical versus oral antibiotic therapy? And what are the current guidelines or recommendations regarding this?
Okay, as I've tried to mention earlier, to choose between topical and systemic IV or oral antibiotics, there are different things. The first thing is the localization of the lesion. If it's localized to one area, very small lesion, you can use topical antibiotics. But if it's diffuse, multiple areas, especially if the areas are more than 5 areas, you have to use oral antibiotics. And the recommendations are like that. And based on also the resistance and the immunocompromisation of the patient, we can decide between oral. If healthy patient, we can use topical, and in immunocompromised, we can use antibiotics, systemic antibiotics.
Okay, thank you, doctor. Question number 12 reads, what are the challenges in managing recurrent furunculosis in patients, and what strategies can be employed to prevent recurrence?
So when we say recurrent folliculitis, that is a major issue currently due to a lot of reasons, but the strategies are we have to have decolonization. When we say the decolonization, as I've tried to mention earlier, it is giving mupirocin ointment on the nasal mucosa. Also, bleach bath is also recommended. So twice weekly bleach bath for 3 months also given, and mupirocin 5 days PID on the nasal and axilla will be given for 3 months, 5 days in a month for 3 months. This is our strategy for treatment of recurrent.
Okay, thank you, doctor. Question number 13 reads, when is it appropriate to refer a patient with bacterial skin infection to a dermatologist or another specialist, and what signs should prompt this referral?
Okay, for referral, most of the bacterial skin infections are medicine sensitive. They have to give them therapy for 7 up to 10 days, and the patient is not responding. It can be due to resistance or adherence or low dose. So whenever they consider if there is resistance, they have to refer to a dermatologist. If it is recurrent and if they think there is a systemic manifestation, they can this can be a reason for referral to a higher institution. Otherwise, most of them are medicine sensitive and can be treated there.
Okay, thank you, doctor. Question number 14 reads, what role does patient education play in the treatment and prevention of bacterial skin infection, and what key points should be emphasized during patient consultations?
There are different types of risk factors for bacterial infections. So this risk factor have to be addressed. That means the first one is like the hygiene, and even sometimes in adults, their immune status have to be checked and the immunity has to be known. And also, whenever there is a treatment, you have to have a plan both with the patient and the other one. Like the general measures include cleaning of the wound with soap and water. Also, wet dressing, like with to remove the crustacean, and other education has to be given. And we have to advise them if there is any worsening, they have to come back immediately to a physician.
Okay, thank you for that, doctor. Question number 15 reads, we don't often get griseofulvin and terbinafine for treating tinea capitis. So instead, we usually prescribe fluconazole, and it's not FDA approved. So what do you think about this?
I'm not sure from where this question came from, because griseofulvin is very available even in health centers. Terbinafine, it's very costly. We don't have it, especially in government setups, but we have it in private setups. But griseofulvin is very available, and we can use fluconazole, even though it's not FDA approved. If it doesn't get griseofulvin and terbinafine, we can use fluconazole, but the efficacy of fluconazole is not as much as griseofulvin and terbinafine. So if it doesn't get griseofulvin or terbinafine, we can use fluconazole as a treatment option, but it's not recommended type of therapy.
Okay. Question number 16 reads, what's the best treatment for recurrent tinea capitis?
The good thing about tinea capitis is currently it's emerging, but antifungal resistant strains of these etiologies are not commonly seen for tinea capitis. Once we treat them, it will disappear. The recurrence is usually due to the contact, because in school children, as we all know, they have a frequent contact from other children, so we don't have any other option. Whenever it is a recurrent, we have to treat them. But one thing we don't have to miss is we have to use adjuvant shampoos like ketoconazole shampoo, because it will decrease the minimization. Also, sometimes it will help us in the prevention. But if it's a recurrent tinea capitis, we have to retreat him. But in the best setups, we can check for the drug-resistant type of strains for tinea capitis. Culture can be saved.
Okay, thank you very much. Question number 70 reads, what is the association of scabies with cognitive deficiencies?
So the problem is cognitive deficiencies, neural abnormalities, sensory loss, and the other is the primary prevention or defense mechanism against scabies is the scratching. Whenever there is scratching, there is exfoliation of these mites from the skin. So in these patients with sensory loss or cognitive deficiencies and the others, they don't usually have this the maneuver of scratching and exfoliating this scabies mites. So that's the relation. The primary defense mechanism, the scratching, will be lost in this kind of patients. That's why they have crusted scabies and other patients.
Okay, thank you very much. So for the final question, I think we kind of touched upon it previously, but can we use ketoconazole 2% shampoo as a preventative mechanism?
Usually we use it as a preventive mechanism, but not to distribute this mite or shedding of mite from the infected person to the other one. Some studies are showing that it can be used for preventive method, but I haven't seen any strong evidence.
Okay, so we have a lot more questions on the chat box, but due to time constraints, we're going to stop addressing these questions and we're going to proceed to the quiz link. So my co-host is going to be sending the quiz link on the dedicated Telegram group. So if you have not already joined the group, we have already sent the link. We will also be sending the quiz link on the chat box as well. So please do make sure to access the quiz link and answer the questions promptly. We will be giving around 10 minutes. Dr. Yared, if you can wait for us until the participants can answer the quiz, and after that we can address the questions quickly.
All right. So the first question reads: a 7-year-old child came with a scar lesion of 6 months duration, and you diagnosed him to have tinea capitis located only on the vertex. Which one of the following is the best management option in our setup? A reads griseofulvin 20 to 25 milligram per kilogram per day for 6 weeks plus 2% ketoconazole shampoo 3 times weekly. B reads fluconazole 6 milligram per kilogram per day for 6 weeks plus 2% ketoconazole shampoo 3 times weekly. C reads griseofulvin 10 to 15 milligram per kilogram per day for 6 weeks. And D reads clotrimazole cream BID for 2 weeks. So, Dr. Yared, you have the floor.
Okay, the question here is a patient, a child, a 7-year-old child, presently with a localized type of tinea capitis, and the question is how we can manage it in our setup. So here we are likely to focus that whether it is diffuse or localized, we have to treat them with systemic therapy, because some misconceptions say patients some treat with topical antifungals. And the other thing is I added in our setup, because we have been discussing about it, the micro size is available in our setup, not the ultra micro size. So griseofulvin 20 to 25 milligram will be the best answer for this question. So we have to treat them with 20 to 25 milligram per kg and for 6 to 8 weeks in our setup. So I think most of them have answered this one.
Yeah. Okay. So the second question reads: a healthy 5-year-old girl presents to the emergency department with her mother for a rash that has worsened over several days. The rash was initially located only around the nose and mouth, but is now spreading to the arms. Physical exam reveals a well-appearing child with erythematous lesions and honey-colored crusts around her nose and mouth. Several lesions are also present on each of her upper extremities. Which of the following is the best treatment? Cefalexin syrup, clotrimazole cream, mometazone folate cream, and fusic acid 2% cream, fusidic acid.
So here the concept of this patient is the patient presents with several days of skin lesion. So here I have mentioned the honey-colored crustes. So this will indicate the patient's having the numbulous type of impetigo around the face, but now it is worsened. So whenever we have, we are going to select an antibiotics. It's based on one, the localization of the lesion, the number of the lesions, and how diffuse it is. So from here, we can tell that the patient is now having several lesions on other parts of the body. So rather than choosing topical antibiotics, we have to treat them with a systemic antibiotics. So the best choice, cefalexin syrup, is the best choice for this patient. But fusidic acid, if it was generally localized, we can use fusidic acid. The others are antifungals and steroids, so we don't use them for the management of bacterial infection. It will worsen.
Okay, thank you very much for that, doctor. The third question reads, what is the best next step if a patient diagnosed with impetigo not responding to cephalexin 50 milligram per kilogram per day in divided doses for 10 days? A reads, suspect MRSA, send for drug sensitivity and treat him with amoxicillin clavulanic acid. B reads, consider it as MSSA and treat with the same medication for longer period. C reads, suspect MRSA, send for drug sensitivity and treat him with cotrimoxazole. And D reads none.
So the concept of this question is, these days there is concern in the increment of methicillin-resistant staph aureus. Also above that, the vancomycin-resistant staph aureus. So the best step would be to choose to send to suspect the MRSA, send for drug sensitivity, and treat them with other antibiotics that have not yet developed resistance. So in the choice A, it is replacement of cephalexin with amoxicillin acid or augmentin is not the right answer, because there is still resistance for amoxicillin and clavulanic acid. And in our setup, the best move will be to treat the patient with cotrimoxazole, especially in children. Other choices can be doxycycline, clindamycin can be other treatment options. So that makes it C, the best choice.
Okay, thank you very much, doctor. So our last question reads, which one of the following anti-scabitic medication is not given for pregnant women? Permethrin 5% cream, sulfur, ivermectin, and D reads none.
Yeah, I've been discussing about special situations, especially for pregnant women and younger children weight less than 15 kg or 2 years age. So ivermectin is not recommended, because sometimes there's some studies show that this ivermectin can pass blood-brain barrier and will have some neurologic abnormalities. So we don't usually recommend ivermectin for pregnant women and children age less than 2 years and 15 kg, less than 15 kg. The others can be given for them.
Okay. So these were the quiz questions that we had prepared. So thank you very much for that, Dr. Yared, and thank you very much for all the participants that attempted the quiz. So with this, we're going to finish our session. Thank you I would like to extend our gratitude to Dr. Yared for preparing such an interesting presentation. It was a very interesting and it was a very informative session as well. Participants were also mentioning that it was a very good session, so we would like to say thank you very much for that. If you have anything to say as a closing remark, let's give you the floor. If not, we can close the session.
Yeah, thank you so much. I hope it has been an informative. I've tried to make it a practical session, and I would like to thank the participants for their warm appreciation. Thank you for the Yetenaweg team, Meron, Simon, and Tadel. You have been very busy organizing this session, and thank you so much.
Okay, thank you very much, Doctor. So have a good night, everyone.